Today's session is sponsored by Cincy. Cincy's HIPAA-compliant virtual care platform and telehealth apps enable your staff to use video, secure messaging, text, and email for your clinician-to-clinician and clinician-to-patient communications. Throughout the episode of Care, clinicians use Cincy's video functionality to engage patients in virtual visits, and multiple participants can be brought into the video call, including the referring physician, specialists, family caregivers, medically certified interpreter, etc. These touch points, whether they are based on video, their condition management emails, or their secure messaging where PHI is being shared, but it's encrypted for safety and security, these touch points are extremely critical during the coronavirus pandemic, as patients may be denying in-person visits, quarantined, staying in place, or practicing social distancing. Visit Cincy.com to learn how to safely continue delivering valuable care and minimize the risk of infection and transmission while preserving scarce PPE resources. We are honored to have two well-known thought leaders joining us today, Laura Wilson, Director of Operations Consulting at Simeon Healthcare Consultants, and Karen Thomas, President at Cardium.
We're happy to be here, Anna Maria. This is Laura.
Yes, this is Karen, and we are excited to be here. So we're looking forward to today.
Okay. Well, let's get started. We'll give you just a little bit of background. As Anna Maria said, I'm Laura Wilson. I am the registered nurse, part of this team. Karen will talk a little bit about herself and her expertise. I have over 30 years of experience in the home care and hospice space. As they say, been there, done that, got the t-shirt for it. I'm proud to represent, in partnership with Cardium and Cincy, Simeon Healthcare Consultants. We are an organization that has been in business over 56 years, and all we do is post-acute, is the home care and hospice space. And that includes consulting in all areas, operations, finance, sales and marketing, mergers. Interestingly, we also have a talent management area, which includes recruiting, executive search, and interim management, which can be such a bridge builder for you, as well as a variety of data analytic offerings, including financial benchmarking, market intelligence, which is becoming so important. So very excited to be here. I will turn this now over to Karen Thomas, who will talk a little bit about her world.
All right. Well, thank you very much. And as I said before, we are excited to be here. I am personally very enthusiastic and passionate about how technology can help deliver or be a really significant part of the healthcare delivery continuum. But a little bit about my history. I am an accountant, so for the clinicians in the audience, bear with me, but I have worked in home care for 22 years. I came from a different industry before that and brought a different thought process into home care and hospice. But in 2002, which seems like a long time ago, we actually, at the home care company that I was with, we actually started a remote patient monitoring program and other types of technology to supplement what we were doing, and found it to be extremely successful in improving outcomes. From there, we also started a telehealth call center where we provided that service for other companies that wanted the results, wanted the outcomes, but did not want to set the programs up for themselves. So I have seen a lot of changes in the technology area regarding home care, and I do believe that home care brings significant value, and the technology only emphasizes the value that we bring to the market. So I established Cardium approximately 18 to 24 months ago, and Cardium's prime focus is to help organizations reduce their rehospitalizations and improve outcomes by deploying what we consider to be best-in-class, innovative health management programs. So what I do and as Laura talked about what they do, I work with Simeon on different projects. But what I normally would do in working with an organization and or Simeon, or in this case, Cinzy, is to help companies decrease their startup cost and increase their implementation, along with strengthening their programs on an ongoing basis. So with that, we develop systems, we oversee implementations and new initiatives, develop new programs, and then make sure that you're enhancing your return on investment. And at that point, I should probably tell you, I'm the accountant in the group. So that's my contribution. Laura and I have sometimes a very colorful conversation on how we should approach things. But Laura is the clinician and I am the accountant. So we all know that we need that income or those funds to accomplish everything that you want to do. So we have a highly experienced team in utilizing technology at home. So I'm excited to be here today and talk to you how you might either implement the program or develop a new program. And we will talk about Cinzy as we go through and some of the things that it can do. Obviously, we can't tell you everything, but we will talk about that as we go through what we see in the marketplace today. So Laura, I'm going to let you take it from there.
All right. Well, we thought we'd let you see at least who's talking today so you get a picture in your mind. Let's start out with what is a very changing landscape right now, almost on a minute by minute. I was going to say on a daily basis, but my goodness, we get CMS changes can come in hourly at this point in response to the national health emergency, the public health emergency that's going on. So one of the areas, and Karen and I both got very excited about this, as well as our friends at Cinzy, because home care is finally being recognized as an area where telemedicine, telehealth, virtual visits can have a huge impact. It certainly is addressing a need with the COVID situations, but we've known for a while that this is something that can be such a game changer for our folks out in the field providing services. So the Federal CARES Act is encouraging telecommunications of all kinds in all areas. Physicians especially, they're moving towards televisits, and they're also allowing home care and hospice to do it. Sadly for us, though, in home care and hospice, they're not reimbursable services yet, I'm going to say, because we're going to stay on that. Once we, now through this time period, we can start proving with data the importance of being able to connect with and engage our patients out in the field this way. So don't forget, though, that if you're a Medicaid provider and some commercial insurances, many states, I happen to live in Minnesota, provides par value for doing visits telephonically, or not telephonically, but virtually. So do check that out in your area. One of the other things that's been relaxed, but Karen will talk more about this because she's very focused on the HIPAA requirements. For the time being, the HIPAA requirement of being a approved secure vendor is being waived. Now, the beauty of working with Cinzy is that then once you put that in place, you don't have to worry about it even going forward, because you will be on a HIPAA, on a secure platform. But for right now, you can use Zoom, FaceTime, those type of apps as well in a pinch if that's what you need to get started.
Hey, Laura, I might
Yeah.
add as we go through and we talk about the using Zoom, FaceTime, and WhatsApps, particularly, they can use it, but at that point, they really don't have anything that enables them to provide their documentation in a uniform manner unless they pull it in. You see what I mean? So
Absolutely.
There's no back office or ability to document as easily if they use that instead of another method.
You are it really becomes just a telephone call, a fancy telephone call at that point, versus harnessing the data that you can get working with an application like Cinzy's application. So, and we'll point that out a little more in depth as we go through the presentation. In home health area, as it stands today, virtual visits, you can provide them to patients via telemonitoring. Remember, you can't just switch out visits, though. You can't just decide that I don't want to go out and see somebody. It has to be part of the plan of care. You need to be specific about it, which visits are going to be done through a tele version or a virtual version, and it needs to be tied to outcomes. So you need to show or that the visit that you're doing, be it physical therapy following up on maybe an exercise program that they're doing, that it advances towards the outcome that you're trying to achieve. One of the best parts of it, though, is we all know that face-to-face documentation is some of the toughest to get a hold of. Right now, practitioners can complete that home health face-to-face visit virtually, which is so great because our vulnerable elders, especially in the home, they're not recommending that they go out and do routine physician visits, that sort of thing. So this allows a way for that practitioner to complete that face-to-face requirement for us without having to bring that person into an office. Reimbursement, oh, here we go. This is where we wish it was reimbursed. Again, physician, it needs to be physician ordered. They're not directly reimbursable for home health. You can't, the visit doesn't count towards a LUPA. It doesn't go on the claim. However, the costs that you're incurring can be recorded on your cost report under the administrative area. And additionally, the various funding that has been given to agencies, to Medicare providers, this would be very much considered if you're standing up a virtual program or a telehealth program. It's a great time to do it because those dollars can be used towards something like this. And don't forget, this isn't exactly about telehealth, but in the homebound status area, you've got some flexibility there now. A beneficiary that shouldn't leave their home because of a medical contraindication. So if they're at high risk for complications that would come from getting the COVID virus, that can be a consideration for them for being homebound. So do remember that. Hospice, very much similar in that most of the visits can't go on the claim. Face-to-face, again, visits for recertification can be conducted via telehealth. So especially important in our skilled nursing facilities where most of the care by physician and practitioners is being done via a virtual service or a telehealth, and trying to limit the number of people coming in. Virtual visits can be conducted if it's appropriate to do, if it again is part of your care plan. The reimbursement is not part of the per diem other than your social work visit, because they were always allowed to use the telephone and to record those on the claims. The rest are part of your cost and can be reported again on the cost report, but are not technically part of that daily per diem in hospice. Okay, Karen, I'm going to let you kick it off. All the different options for teletechnology.
All right. Well, there's a lot of different ways we can use technology, and I'm sure some of you have developed some of your own. But the first thing that since we have a limited time, because I can, here again, here's my passion, but I want us to think about looking at technology with a three-pronged approach. So we'll talk about COVID and how that has impacted the use of technology and some of the things that you can do, and actually maybe some of the things that you can take to your referral sources to let them know that you're doing, which would support what they would like to see. I'd like to talk about normal use and maybe the potential of new program development, and then the connectivity to staff. And obviously in this time frame, we're going to hit all three of those at maybe a 30,000 foot level. But my goal here is to prompt some thinking and lots of questions. So the other thing, as we go through here, I want you to think about, along with that, on the normal use, not only for Medicare, but think about how you might maintain your referral base and your connectivity with your clients by moving this use of technology onto private duty, as far as utilizing it in a private duty sense, if you have a private duty program or not. And then some people look at private duty as to whether or not they think of people just paying, but it's also whether or not there is a hospital, for example, that has a problem in your area and you can provide a service that is not normally paid for example. So think about that private duty, and then we'll talk about hospice as we go through here. So the one thing I want to say is we just want to also like pull this together in short and say we want to work with you to help you develop new client responses and communication and a new way of triage. That's really where we are. And it's sad that it took a pandemic to push people ahead to allow us to utilize the benefit of technology. But obviously, I can tell you they wouldn't have done it if they don't think there's merit in it. They were just a little slow in how they were going to approve it as time went on, despite the fact that we've spent so much time educating them. So let's talk about COVID, because that's really something that is, I mean, think about it. So you've got a home health company, you've had the PDGM change, and all of a sudden, just a very short time after that, you have COVID. So now you're facing all those different problems at once. And I want to say, I get it. I was a president of a large home health company, and so I know the look that everyone gives you when you say in the middle of what they seem to think is a crisis that we want to do and implement something new. But despite their feelings, if we can explain how it's really going to help them get past this and utilize to do the things that they need to do, and that it implements quickly, I think it will be fairly well received. So when we're talking about COVID, we want to think about protecting our employees, protecting our patients, utilizing the employees at the best advantage, and decreasing the use of PPE for obvious reasons, because if you can get it now, it's more expensive than it was in the past. But with the video, Laura, and I'm going to pull you into this because we've talked about this together, but with the video, with COVID, there's a number of things that you can see. So you can ask the questions, as you know, Cincy has programs that you can ask questions or push out information to educate your patients. But Laura, let's talk about particularly the hypoxia and maybe even being able to take a pulse ox and show it on the screen, but particularly the silent hypoxia. Let's talk about that, because I think it's important to them and it's something they can take to their referral sources.
Well, exactly. I actually heard a physician speak on this last week, and he called it the happy hypoxic. So in that, you can be very seriously oxygen starved with this disease and not be aware of it, not feel really short of breath. And it has to do, I won't go into the whole mechanics behind CO2 and oxygen and how it's transferred, but people can come into the emergency room and have O2 sats in the 70s. and still be talking on their cell phone and not realizing just how just what kind of trouble they're in. So having an ability to virtually connect with people on a frequent basis, this is one of the things, along with temperature, that is really a defining issue with this disease. And again, it can be silent. It can be something that you don't even know. So a simple pulse oximeter out there that you can see a reading on, even if they don't understand how to read it, just have them hold it up to their phone and you can take the reading.
Well, and we were also discussing too, like the nasal flaring of a patient and the, counting their respiration, looking at their respiration rate. So all those things
Yeah.
that,
Nasal flaring is
yeah,
what the easiest way. One of my pediatric physician friends told me the easiest way to tell somebody's hypoxic, even if you don't have that, is while you're talking to them. If their nostrils are flaring, chances are you've got some sort of oxygen deprivation going on.
so with that, then that's really one of the ways that you can actually take patients that have been in the hospital or have been, that have been diagnosed with COVID-19, but you can track how they're doing at home, or you can take a patient that you can actually, so think about this, and we'll pull some of these together now. You can't see my hands, but I'm pulling my circle together, but we would look at a lot of these. So let's say that, let's connect the dots here. So you've got the communication platform, you have this patient, and you can actually, maybe it's a home health patient, or maybe it's a patient that the doctor has realized that they're either at high risk or already have COVID-19, but not as seriously ill. So you can continue to watch that patient. You can order the oxygen from a DME company if they need it, and you can continue to watch. So this patient would only go to the ER when you have done everything possible for them to keep them at home, but at the same time, their physician knows what's going on a daily basis, or maybe 2 or 3 times a day. So it's, as I always tell people this, and I look at it as, think of this technology as connectivity with a purpose.
Mm-hmm.
So what purpose is it that you're doing? And being able to look at the COVID patients, and really it applies to so many, you're going to be able to prevent these ER visits. You're going to keep them out of the ER, and maybe they're just scared. So many people, think, oh my gosh, I'm, really, my chest is tight, I'm having trouble breathing. Well, unfortunately for all of us, this came at our allergy times of year. So you can do a lot of things to prevent these people from going to the ER and possibly being exposed to other patients. So with that, when it comes to patients that you have, it can be a new referral source. You're going to prevent maybe visits to the doctor. So let's go there. So we've actually had physicians call and say, I need to do something because with my particular population, they're high risk, and I don't want my patients coming in to see me if they think they might have COVID-19 unless I can isolate them, and I want that information. So they're looking to gather this information before the patient ever comes in. So we're looking at protecting that patient. We're looking at the same way with all this information that we have. So now take it a step further. So you have a client, you can get this information, but you're protecting your staff by 2 things. One, the staff knows very specifically what they're dealing with once they go in the home. And then second, as you gather this information and you have the ability to do these video visits on Cincy's communication platform, then there may be times when they don't have to go into the home. There are other things that they can do, and how they perform that video visit and the information they can gather from the patient, that they don't have to go in the home. So once again, they are not exposed to other people during this time too. So you're protecting your staff. So now pull all that together, whether or not it's COVID, and we'll talk about chronic care issues in just a second, but you're being able to do that. You're maintaining your contact with your patients. You're not driving someone out to the home. So anytime you don't have windshield time for a clinician is the conservation of a great asset, in my opinion. I have the highest respect for people that actually go out to the home and provide these services. I've been in many patient homes, so I know um, what they do and how important they are. So you're protecting, you are conserving your asset, and you're maintaining the contact with the patients.
Can I add one more thing in there, Karen?
Of
You're,
course.
you're also preserving PPE at that point,
That's right.
which we all know we were the last people to be thought about who might need PPE. It's improved some. They've started focusing a little bit on the community, and we've gotten quite savvy at getting a hold of it. But this is one way, by not having to go into that home, you you don't need to head into the whole donning and doffing of PPE while you're trying to get into your car at the same time.
That's right. Well, and along with that too, so now I would like you to think of all the very same things that you can do for this population, complicated by COVID, for your chronically ill patients. So you've got, in fact, I read just this morning, don't quote this because the people didn't say what their source was, but 40% of the population over 65 have 2 or more chronic illnesses. So you already have a number of patients. So when you're going to your referral sources, you can say, this is how we're contacting the people. This is how we're staying in touch with them and with their chronic illnesses. So you're really making sure that they don't have COVID-19 when you're checking it, or you're just actually doing all these very same things by taking care of their chronic illnesses. And you know it's important now to CMS that they would actually say that a person can go on home health if they are at high risk for contracting COVID-19 if they leave the home to go to the doctor's office. I have to say, as many years as I've been doing this, I was surprised at that one. Weren't you, Laura?
Mm-hmm.
Yeah, I was very surprised at that one. So then, that when we think of that communication platform, I also want you to go, so now in the normal routine, and it also goes with COVID, so they go hand in hand, but the solution to reducing visits to patients. So I want you to think about that very carefully, because I've worked with a number of people that say, well, I use this technology and my visits increased. Well, yes, in some cases that happens, but it happens because people are not stepping back and really integrating the technology into their everyday workflow. And we'll talk a lot more about that on the next slide. But then, so with that, I want you to also remember the importance of being able to use this communication platform to communicate with your staff and make sure that you're engaging the staff along with the patients. Now, we can say with COVID-19, we're keeping them at home as much as possible. That's absolutely correct. But if you step back and think of what all of us do in home care and how dispersed we are among different communities. So you can say, well, I have many miles to drive if I'm rural, but you can have fewer miles in a highly urban area, but you sit in traffic for a long time. So you've got, the more you can communicate with these people from where they are, whether they're at home or where they're living, then you're much better off. And the other thing I want you to think about is if they become very comfortable communicating like that with you, they also become very comfortable with communicating with their patients, and they're more apt to work their patients through any hesitation that you have. So it becomes a way of life for them, and they're comfortable with making it a way of life for their patients in addition to that. So then the other thing is video visits. I've seen a lot of people working with video visits, and what they're doing there to keep, once again, to save the use resources, they do a couple of different things. Some agencies have actually, maybe they pushed out a video, but others are observing a patient doing exercises, or they are observing, for example, a PTA doing a visit where they have someone in the office that's observing people working with the patient in the home. So there's a lot of different ways you can do that. I have worked with agencies that have actually tested the measurement of extension and flexion via video versus it being done in person, and it was very, very close. In some cases, only 2 degrees difference. So there's a lot you can do with that video. I've seen successful programs where people have given assistance for speech therapy, for example. So all of these programs need to be well defined, and we'll talk about that too. But so there's another use for those virtual visits. And monitoring wound care. We all know that we get some really tough wounds in home care, and wound care is a great use for these video visits. And in fact, as I was working with Sensi, they've mentioned some of their clients who've had a drastic improvement in their wound healing time or their rehospitalization and the care or the quality of care for their wound program. So that's another area I think that you'll find it's very worthwhile. And we'll talk about data with all this in just a second. And then for someone who's had family members on a family member on home care, I'm also very sensitive to the fact that we need to prevent social isolation. And right now with COVID, we need to alleviate the fears. And what better way to do that is to have a platform where people, the nurse or therapist, can be talking with those patients and pull in family members or a physician to do those video visits too. So you're keeping people connected. And I can tell you that as I watched someone who was 100 years old FaceTime with great-great-grandchildren, they are, they're very comfortable with it. You know, they are much more comfortable than one might think with the technology. So I think on the next one, let's talk about, before we get too far in and lose our time frame, but let's talk a little bit about that roadmap on some of the things that you need to think about, whether or not, if particularly if you want to start a new program, or second, let's say you have a program and you're really thinking about why it hasn't grown, or you would like it to grow with a new specified program or a new opportunity that you would have. So with that, let's look at what would you really do first. And I would like to preface all this by saying, for those of you, I'm sure all of you have an electronic medical record. And when you think about what you did to prepare for the implementation of that electronic medical record, you know, there was a lot of data mapping, there was a lot of, you know, workflow analysis, there were a lot of work that went into it. It's kind of like preparing a contract before you actually do anything, a lot of detail before you actually see anything happen. I want you to think about implementing a program for technology in the same manner. It's much smaller, but if you put in the effort up front, then you're going to be much more successful as you go. Too many people will purchase the technology, the platforms, the software, and then they're uncertain why the program really didn't work out well. And I think agencies are becoming more and more savvy in that regard, but this will be just a few little tips, or hopefully there'll be a nugget in the slide that you might find helpful. Particularly when we look at dealing with chronic care management and COVID-19, and quite frankly with PDGM as we move forward, the question is, we have to decide, what problem are we trying to solve? We want to do more than just have a communication platform. We want to know what we want to do with it. So the key there is to actually list this out, so we'll know, are the resources available, etc., how we're going to do it. So once we determine what the problems are, then prioritize those problems, and along with that, the time frame that we think that it would take to accomplishment accomplish that and our staffing concerns. So here's an example. Let's say that you have a COVID patient or any patient with wound care, but it's a lack, maybe there's a lack of staff in your area, and you can benefit from, for example, a WOCN in the office assisting, developing a program to assist with the wound care in the field, but not necessarily having to go out and see that patient. So you're reducing your distance to travel and you're addressing your lack of staff. Or once again with COVID, which we've discussed fairly in depth on the prior slide, is that we're keeping people out of that home, protecting both our patient, our staff, and working with our referral sources to meet their needs. So we're really connecting the dots with that in particular. So one of the things may be that we need to reduce the cost. So I'd like you to think too, who's available to design and implement the program? Do you have someone in-house or do you need assistance with the project? So how will you communicate this to the staff and get them on board? So what is the program? How do you want to design this program, and what patients you're going to be working with? So identify, it's very important, and we'll get to, when we get to the data, it's very important to know what is your client criteria, because many times poorly defined criteria, we miss patients within our census that could really use a communication platform, the video visits, and for some reason we may have excluded them or not included them in the program. So the next thing is, let's think about what is our technology available. And obviously you understand, I think most of you probably understand what this, Sensei's communication platform does and how it would apply. So once you find that problem and really look at how you can either apply it as it is, how you can adapt it, and how it will apply very specifically to your group of patients that you want to accomplish. The next thing is clinical expertise. Now, I know we need nurses and therapists to do this, but I have found over the years it's very enlightening and productive to be very open and honest with ourselves and look at clinical expertise. And the reason I say that is not because the nurse, whoever it is not good clinically, but just remember that when you do this, you need to have, when you're working with video, you need to have different communication skills and triage skills because you're not actually touching this patient. So think about what clinical expertise you have in regard to the communication and the triage. So then with that, we'll think about our training tips and what it is that we would do. And so how we would implement this with the clients, but how we get the clients to accept it. What is it what are the obstacles out there, and how do we communicate what it is we want to do? I'll give you an example. I talked with someone the other day, and they were struggling with getting people to accept their program. And so I asked them what they said, and there was a long clinical explanation of why it was so helpful to the patient. And my comment was, well, you lost them 2 or 3 sentences back. The key is this is to protect them. Their physician also wants them to have this care. And your whole goal is to see that they stay healthy, they manage their disease process, and they don't go back to the hospital, for example, or they don't go for the first time. And those are things that people understand and relate to. I will say this, research what it takes for an adult to want to learn, because you will find that it is very different. And to do this, to implement it, and to get the acceptance, that will be very important.
I jump in here really quick too, especially in times now with the public health emergency. going on and we're trying to find solutions quickly. Sometimes we're standing up telehealth. One of the keys that we've heard from some of the larger webinars that have been given from like the VNS of New York, the folks out in Evergreen in Washington that were really some of the first people dealing with the coronavirus and those patients, is make simple tip sheets for everyone, employees and patients. Show screenshots. Make it easy. Do it in whatever their native language is. So if you have a large Russian-speaking population or a large Spanish-speaking population, you're going to want to get it into a language that they can use. And they couldn't stress that enough, that people are right now are anxious and under stress, and you can do teaching and training and they walk out the door and the knowledge goes zing right out into the clouds. So anything that you can give in very simple terms, the better your rollout will be.
I agree, Laura, and connecting with that patient. And that's why when we talked about being able to use this for your staff, if you can't connect, if you're not connecting with your staff, then they're not going to do the same with their patient. So whoever, do you see what I mean? So it's really important to connect those dots and make sure they understand. And adults have to have a reason to learn. I spent, it was really interesting researching why adults are willing to learn something. And I think you'll find it very beneficial for your programs. And then, as we go on, so understand your operational efficiencies and your ROI. So as an accountant, I know not everybody's crazy about us, but at the end of the day, they all need us at one point in time. So I would say this to you: understand how efficient you are, and are you getting the return on investment? Because with that, then if everyone has someone they need to go to, or if you're the owner, you want to stop and think, am I using my funds very efficiently? And am I getting, do I have a return on my investment? And if you need to track, are you accomplishing your goals? What was your goal? Was it to reduce the drive time? Whatever it is, was it to reduce the drive time of your clinicians? Was it to reduce visits? Was it to get more referrals? Was it to keep reduce your PPE costs? Know exactly what it was you wanted to do so that you can actually either tell yourself if it's your responsibility and prove it to yourself, or prove it to someone else. So when you want to grow your program, you can actually say, okay, here was our goal. Here's what we intended. Here's what we did. And yes, it was successful, not only clinically, but financially. And there may be some that you just want to break even, but just know that you need to understand that as you go ahead. And then data, know up front what you want to accomplish, and then start to track that data. I mean, I track many things. So is it a certain ethnic group that maybe there's a culture that you need to change? Was one group have a better acceptance than the other? Was it 2 to 3 comorbidities? Was it COVID and we needed to change what we did? There's all types of things that you need to track. And I'm going to tell you a mistake I made, and I have to admit I've never done this on a webinar, but here's the advantage of tracking data. I actually worked with a company that we did a random control trial. I mean, by the book, all right? And it was for CHF patients. And the outcomes were fabulous, all right? And they are 30-day readmission was 75% less for those people that were using technology. The 6-month readmission was 50% less. But guess what? After 6 months, the people went back in the hospital. So what we found, because we tracked that data 6 months afterwards, we did not do we're not best practice at teaching that person how to care for themselves. So as a result of tracking that data, we went back and changed our teaching methodology, did it again, and then found out that people did much better in caring for themselves. So you will always, if you evaluate your effectiveness very honestly, then you will be able to continue to improve your program. And with that, obviously, doing all this, then you will be one of the preferred providers in regard to referral sources, because when you start the program, you're going to be asking them, what is it that they need what do they need, and how can you offer that, or how can you help them reach their goals within your programs? So with that, that's really kind of a 30,000 foot view roadmap, and I'm hoping that some of those things were significant for you. And then on here, so some suggestions that we have. Laura has mentioned the tip sheets. Laura, I don't know if you want to add anything about tip sheets that you didn't mention.
No, that was kind of it. So,
And they need to be simple.
yes,
They need to be simple.
simple and in a native language. So,
correct.
And with pictures, if at all possible. Screenshots, so important.
Yes. There has to be a comfort level. Just remember, a comfort level for both patients and your staff. The other thing is, as you're doing this in regard to how you set your programs up and what you're doing, make sure that you have this education material for your referral sources. You know, it's a brand lift, because you can be accomplishing a lot with their patients. But right now in particular, I mean, everyone's busy. You know, how long do you really spend with your physician when you go see your physician? You know, how much time are you actually talking with them? So you need to, it's up to you to provide appropriate education material to be able to show that you've generated the outcomes, and let your referral sources know that and update them periodically. I do like to say to people, the fact that you have the technology is not what your referral sources are interested in. Really, they want to know what outcomes, what changed with your patients as a result of the use of technology. That's really what they're looking for. And then that ties back to what we talked about. Track that data, track that data, track that data. Then Laura may have something that she wants to say about this, but it's very important that you refine your physician's orders, and whatever you're doing, however your program is set up, whether or not they're as needed visits, whatever the case is, those physician orders, the use of technology needs to be tied into that order. Laura, I'm going to let you have it there, because
and remember, tied into some of the first things that we talked about were the fact that the televisits, the virtual visits, need to not just be, oh, I don't feel like going out here today. It needs to state explicitly the goal and outcome that you're trying to achieve and what type of visit you're planning on doing. So if you're supplementing, which is my sense is probably what you're doing, since they don't count as visits made, especially in home health and PDGM, you can have, we've seen a real increase in LUPAs in the March and April timeframe from data that we're getting in. So be sure to relate it to, this is continuing your plan of care by allowing additional education, teaching and education and patient engagement towards helping them better understand their heart failure disease or something like that that's specific. Remember, it needs to be part of the plan of care, part of your coordinated plan of care, even in your hospice area. And the PRN visits is a really good, is some really good advice. And especially is one where in the middle of the night, I was talking with a hospice provider just yesterday, and they are using that virtual technology, especially if you've got some rural areas that you're going into, It's a way to get a nurse and a face on the phone or right in front of you right away. And it might be a 45-minute or an hour drive to get to them. And we all know that things are scarier at night, especially if you're one of the caregivers for a hospice patient. So they're having a great deal of success using this as a way to connect with patients.
And Laura, I'd like to add, to, particularly for hospice, not only it is a great way to communicate with the patient, but usually it's the family member that is in distress, not knowing, often in the evening and unsure what's happening. So
Yes.
it does give that opportunity to provide a source of knowledge and or comfort to the family member, or you can actually see what's going on with the oxygen tank, et cetera, et cetera. I had, yeah. So, I mean,
Yeah.
I know this, another funny story, not too funny, but we, working with a patient, there was an oxygen issue as far as their pulse ox, and they weren't doing well. And fortunately, the monitoring nurse actually said to this patient, would you take your tablet over there and let me see the oxygen tank? Long story short, they were getting ready to send a nurse out because this gentleman was in distress and he turned the tank off accidentally. So, he wasn't getting any oxygen.
Right.
But as something as simple as that saved a visit, and obviously they felt better about the situation. Now you get all kinds of different things, some very serious, but being able to see, I think we all know, just make the most use of it. And then, we talked about earlier on training for video visits and being able to communicate and triage. And this is just a little, some tidbits that we would add. Make sure that the lighting is good where you are, particularly if the nurse happens to be in their own home and they're talking with the patient. And also, when they set this up with a patient, try to figure out that you're going to have proper lighting or where that patient can be in the home, or suggest moving a lamp. I know it sounds tedious, but actually it'll make a lot of difference at a time when you may that lighting will be instrumental in being able to figure out really what's going on. And then portable green screens that will actually clip on the back of your chair like great big car shields for sunlights. And unfortunately, I don't have time to tell you some of the odd stories that we've had with people being able to see the background, but it's also a HIPAA issue because it screens out everything behind them.
In the home, remember, that's both on the employee and the patient side. So we recommend, Amazon has a portable green screen. I have one that I use doing the virtual things. In a patient's home, oftentimes even just suspending a sheet over an area can act as a backdrop for them that then doesn't display anything that might be HIPAA specific or that they just really don't want to show. And that's okay.
Yeah. And then with that too, so assessment guidelines, you need them. So take the time to write them up in the beginning because it is different for those that are not accustomed to providing assessments via video. Also, what documentation is needed. And then very importantly, how do you engage that patient? It is a different method of patient engagement, but think those things through first, because always remember my history with physicians, you usually get one opportunity to impress them or a referral source, and it's a lot harder to undo it. So with that then, so we have some suggestions, and I know we've talked about some of these. I'm trying to watch our time, so I'll just highlight some, but we've talked about the patient criteria and triage protocols. So establish good internal protocols. That's very important. We haven't mentioned that yet for your virtual communication. So it's used for whether or not you do IDGs, IDTs, case conferences, communicating with the physicians, pulling a physician into a call with the patient. Just make sure that you have internal and external protocols so we know who's going to identify who, when does it happen, what do we document. That's very, very important, particularly for later when you're surveyed. But adapt all of your workflows and communication to include your virtual care. That's how you will get the best result, how you will accomplish what you have set out to accomplish. And then in this case, if, thinking about defining your deployment methodology, that is where people are working with their, do they have the tablet? Can a family member get them the tablet? How are, teaching them to download an app, for example? So just know that those tedious things will make a huge difference. So Laura, I think we've got some pull it all together tips that we talked about.
Exactly. Just to review kind of what we've been talking about, know the waiver details and regulations and know when they change. So keep an eye to the CMS websites, especially as Karen mentioned, that HIPAA one, neither Karen or I expect to have that last, the relaxed HIPAA areas. So going with a product like Cincy really solves that problem for you. Remember, don't try to boil the ocean. Figure out the problem that you're trying to solve and avoid the trying to solve everything all at one time. Take one part at a time. Determine your appropriate telehealth telecommunication. Certainly we've got a good one here that we're talking about. It's something that Karen and I are available to assist you with if you need it. Get help as you need it, finding out what your options are out there and what your particular geography is like. Stay focused. We again emphasize beware of that scope creep. Don't try to solve everything at once. Karen's talked very specifically about data. Track it. This is the time that we can use data to make a case for why this should be a ongoing part of our plans of care in our post-acute services. And as we go through all of this, people are stressed, mistakes, there's confusion, things change. We just say have grace with each other as you travel this. Take a breath before you get irate or angry about something. It will, as my mom used to say, it will all come out in the wash eventually. So
easier said than done, Laura, but we all agree. Yes. So we've been there. We know that's easier said than done.
Exactly.
So I guess Anna Maria, we'll turn it back over to you.
This was a terrific presentation, Laura and Karen. Thank you for such an engaging delivery of critical information for everyone to keep in mind as they move forward in delivering care, both in person and via telehealth. We've had two questions. One, which right away I'll just let everyone know, we will be sending a recording of this presentation out as soon as it is available to everyone who attended as well as registered for today's webinar. The second question, there's two parts. One, which is a telehealth visit reimbursable in hospice for social workers? And then the second part of that question is a social work reimbursable in home health? You may have touched on this earlier, maybe in the first, say, 10, 15 minutes of the presentation today.
That's okay. Quick answers, yes and no. In hospice, the MSW you can put the virtual visit on the claim because telephonic visits are allowed in under hospice regulations for MSW only. That is the only discipline. Everyone else, you can't put it on the claim. Sadly, in the home health care bucket, nothing is reimbursable directly. It is indirectly reimbursable in both products in that you can count the costs on your cost report. So you can attribute the costs and the different CARES money that we're getting, the the advancements, those sorts of things. This is a very allowable expense. Just make sure to keep good track of that. Simeon has done a number of presentations on the accounting behind how to keep track of all that, but this is a great time to get telehealth inserted into your organization. Hopefully, if we keep enough data and show the outcomes and the ROI on what we're doing right now, we can make this a permanent part of our plans of care and make it an allowable service.
That's true. It is truly a watershed moment for the delivery of care and will change how everyone expects to receive and deliver care in the future, not just in home health, but throughout the healthcare ecosystem.
Exactly.
If there are any additional questions, both Karen and Laura have kindly provided their contact information on the next slide. Feel free to email them directly. Also, this will be available in the recording that you'll receive within a few days. This concludes our webinar presentation this afternoon. Thank you, everyone, for your time and your interest. Please be safe and be well. Take care.
Thank you.
Thank you.